He is a senior advisor and head and neck consultant at Command Hospital, Lucknow. Dr. Mitali Dandekar, she is the chief consultant of head and neck surgery at Paras Hospital, Patna. And Dr. Karthik Krishnan is assistant professor of head and neck surgery at Tata Memorial Center, Mumbai. Dr. Teja will be presenting the case today. He is the MCH resident at Tata Memorial Center. Teja, are you there?
Yes, sir. Yes, sir.
You can switch on your video.
Okay.
And before I begin, I would request all the residents who are there to see how the different cases can be presented. What are the things, what are the flaws that we tend and the mistakes that we tend to make during the presentation. So that more you present, the better you become. So it's an opportunity for you to learn and develop your skills of writing or giving the examinations, and also understanding how the presentations can be made better. So I welcome you all. And before we start, we have a wonderful team at the Mahamana Pandit Madan Mohan Malviya Cancer Center. And we have Dr. Ravi Shankar with us.
Hi.
Dr. Komal Lamba, she is the assistant professor with us, and Dr. Nisha Akali. And we have a wonderful group of residents as well. So all of them will be learning and all of them will be subsequently presenting. So it's an honor for us also to learn. So as Teja presents, these residents will also gain a lot. So welcome you all. Please, we'll start with the session.
Ravi sir, could you disable the screen, please?
I didn't get you. What do you want me to do? Screen sharing?
Host needs to disable screen share. Let me share the screen.
Screen sharing.
Yeah, okay, thank you.
Okay.
Yeah. Good afternoon, everyone. Good evening. Shall I start? Hello.
Yeah, please, yes, go ahead.
Sure.
Today I am going to present on case on early tongue cancer. My patient, Mr. X, is a 33-year-old male resident of Mumbai, businessman by occupation, with no history of any COVID symptoms now at present. Presented to our OPD with a chief complaint of ulcer over the right side of the tongue since 4 months. To start with, the present complaint started 4 months back as a small ulcer of peanut sized on the right side of the tongue, which is of insidious onset and gradually progressed to the present size. The patient also has complaint of pain, which is at the local site, which is of moderate intensity and relieved by medications in the form of analgesics. And he has also associated referred pain to the ear, which is also occasional. History of associated excessive salivation and foul smell from the breath is present. There is no history of difficulty in swallowing, chewing, or articulation or speech. And there is no history of sharp teeth or repeated trauma associated, no history of any swelling, no history of any bleeding episodes, no history of change in voice, cough, weight loss, and bone pain, and other issues. He is a known tobacco chewer since 5 years, and he reformed since last 5 months. He is not a known alcoholic or smoker. There is no past medical comorbidity history or no history of any allergy, no history of cancer-related history in the family, no history of treatment in the past for the same oral complaint or itchy. To summarize, my patient is 33-year-old male with a tobacco chewing habit with ulcer over the right side of the tongue, which is insidious onset and gradually progressive with referred otalgia. Shall I proceed? In general examination, he is conscious, coherent, well-oriented, moderately built and nourished, with normal rest of the parameters with normal limits. And local examination with informed consent and in a well-illuminated room. On inspection, the mouth opening is around 3.5 centimeter with poor oral dental hygiene and nicotine stained teeth. There are no OMSF bands and there is no loose teeth identified on inspection, and there is no restriction of tongue movement, no ankylosing, or there is no deviation of the tongue present. There is no deviation of tongue present. On further inspection of the lesion, it is 3 into 2.5 centimeter also proliferative lesion involving right lateral part of the tongue with rolled out edges, involving specifically anterior to that on the lateral aspect of the tongue. It is 2 centimeter behind the tip and laterally floor of mouth is free. It's a well lateralized region and away from the midline. Posterior border can be delineated, but distance from the circumvallate can't be, but it is well away from the circumvallate papillae. There are no visible SARS, kinesis, or neck swellings. On palpation, mouth opening is adequate, and with adequate mouth opening, all the inspectory findings like size and extent of the lesion are confirmed. It is 3 into 2.5 centimeter only, and induration is not extending beyond the visible growth, and it is 2 centimeters from the tip. Laterally, floor of mouth is not involved. Medially, 1.5 centimeter away from the tip, and posteriorly 1 centimeter away from the anterior from the CVP, and there is no palpable cervical lymphadenopathy. To summarize, my patient is 33-year-old male with tobacco chewing habit with ulcer over the right lateral wall of the tongue, which is insidious onset and gradually progress to present size with referred otalgia, and there is growth involving right lateral border with indurated base, and there is no palpable cervical lymphadenopathy. So my diagnosis is it's a malignant ulcer, right lateral border of the tongue, most probably of squamous cell carcinoma, clinical stage T2 and N0.
May I speak? Hello.
Yeah, hi. I think, yes, ma'am, sure, please go ahead.
So Dr. Teja, well presented. I'm looking at your last slide. You said it is SCC tongue C2, CT2N0. I would be interested to know the third dimension when you say that it is an indurated base. As of today, did you see palpate and tell us, could you tell us what the third dimension is clinically?
Third dimension can be thickness, ma'am, or it can be depth of invasion, ideally. On palpation, the depth of invasion can't be accurately measured, but
so why is it not CT3N0?
Based on the size of the lesion, it is T2, ma'am, and depth need to be evaluated further. Based on the clinical staging, it is, and I need to have a radiological staging along with that to confirm regarding the depth of invasion.
Okay.
Yes, Teja, but now due to the recent AJCC staging, it is important that you should mention in the examination finding that you have tried to assess the depth of invasion because it is a part of the recent staging. So you should mention it.
In the terms of thickness, I will mention.
Yes, or in that you have looked for the depth of invasion.
So, Dr. Teja, I just have a few observations with respect to the presentation per se and what you have mentioned. See, when we say clinical includes radiological evaluation. So, unless you have an imaging, you cannot say clinically T2. Clinically T2 implies that you have clinico-radiological correlation. Thereafter, only you can say T2 and N0. Okay. With regards to the previous presentation, although there are small little things, see, you can't have restriction of tongue movements / ankyloglossia. It implies the same. Similarly, you don't need to be an alcoholic to develop disease. It is the habit. It is consumption of alcohol oblique consumption of tobacco or a smoker. You can't say he's non-alcoholic. A person who socially consumes alcohol is not an alcoholic. So these are small things. But coming to this slide per se, when you say clinically involves an imaging. If you want to stage any disease, clinically involves imaging. And when you say squamous cell carcinoma, you need to have biopsy with that. As long as it is malignant ulcer, right lateral border, it's fine. But when you say squamous cell carcinoma, you need to have a histopathology.
I agree, sir, but the classical teaching is the most common is common. Squamous carcinoma is the most common, out of which in oral cancer, squamous cell is the most common. So,
absolutely, undoubtedly, but you still cannot
and
say
rolled out edges,
diagnosis.
rolled out edges in a clinical picture is graphically pointing out for ulcer.
You
So
still may say my provisional diagnosis. You still cannot say diagnosis.
Okay, provision.
Diagnosis implies that a histopathological examination or a needle aspirate was done to confirm the nature of the disease or the histology of the disease.
Yes.
Yes, please go ahead. Would you like to show us the images?
Images of. Yes. This is MRI picture showing the same lesion, which is involved in lateral border of the right side of the tongue, with approximately depth between 5 mm to 1 centimeter in between. And
How can you say this
the
is tongue and
axial
this is not palate?
This is a mandibular arch here, sir, and we can see the tonsils here with the oropharynx here.
So all you can see is an alveolar arch. You
and
can't clearly say whether it is maxillary or
oropharyngeal.
mandibular. Yes. So probably you are visualizing the palatine tonsils.
Palatine
Right?
tonsil with the oropharynx. Yes, sir.
And the pterygoids.
Yes.
Okay, so this is an axial section.
Axial T1 weighted contrast image, sir. This is the coronal section and this is sagittal for us.
So can you point out certain normal anatomical landmarks in the coronal pic?
This is a lesion, sir, and this is a lingual neurovascular bundle here. And myeloid sling will be somewhere here below the neurovascular bundle. And that much only, sir.
All right, go ahead. What do you see in the SAG image?
So as image, showing a lesion again here on the lateral border, and it is pretty limited to the anterior two-third of the tongue, not extending beyond to the post BOT.
All right, go ahead.
Now that we are on the MR, Dr. Teja, can you tell us when will you see the axial? I mean, for what particular reason will you look at the axial? For what particular reason will you scout the coronal? And what particular reason will you look at the sagittal? Like you said, sagittal, it will tell us whether it is in the anterior two-thirds or no. When will you look for the axial and when will you look for the coronal? I mean, what will you look in particular?
To identify first tongue lesion on MRI, still images are to be taken into consideration. On identification of the still image lesions, then you will go to the axial T1 contrast image to see the size and extent of the lesion. Along with, if possible, depth of invasion can be calculated. And in coronal, you ideally see myeloid sling on involvement of neurovascular bundle. And in sagittal,
Yes, go ahead.
and in sagittal, you see, you draw a imaginary line from the junction of soft and hard palate to the head. So if the lesion is anterior to that line, that is indicating that it is involving anterior two-third of the tongue. Axial, you can better have a look of hyoglossus muscle. Genioglossus muscle can be seen in all cuts, and coronal is for better delineation of mylohyoid muscle, which corresponds to the floor. So floor extent can be better delineated in the coronal section.
Okay. Go ahead. Do you have anything more?
No, ma'am, this much. And
Okay, Dr. Teja, let us begin with the etiology of. What are the known etiologies of oral cancers?
So, known etiologies are tobacco, alcohol. And, if you come for oral cancers, areca nut and HPV as a viral cause, and others non-specific like poor socioeconomic status, poor oral hygiene, sharp tooth, repeated dental trauma, and
Independent etiological factors.
alcohol, tobacco, and areca nut are independent.
Any other?
We are talking about independent. What Dr. Mitali is asking is independent, which means that one ideological factor per se in itself being a factor causing the cancer.
Okay. This tobacco, ma'am, one dependent factor.
You said areca nut by IR. Is it independent or not independent?
Areca nut contains a tobacco in it, but
Is
areca
it?
nut can also independent
No,
in different forms. Okay, so
So areca nut is an independent independent etiological factor, and I guess areca nut and tobacco cannot be taken together. I mean, they are separate from each other.
yeah, IRC grouped under group 1 carcinogens, ma'am. This
Yeah.
tobacco,
Okay. Amongst
including alcohol.
if a patient is a non-tobacco, non-alcohol consumer, what are the other risk factors?
Independent risk factors per se causing the malignant transformation.
Non-tobacco and non-alcoholic with
You did mention it. You did mention it previously.
sir, HPV, it is viral etiology causing the cancer.
HPV in
It
oral
can be
cancers?
sharp. Yeah, ma'am.
Okay.
Literature says, based on our ICGC project, it is 26% with buccal mucosa, and for tongue cancers, approximately it's around 40%.
Association
HPV as
or
a cause.
attribution?
Otherwise,
No. Please
Association,
listen to
it's
what
association.
Dr. Mitali is asking. She's asking, is it associated as a factor or is it per se as a viral cause causing the cancer? See, oropharynx, we all know that. And in majority of the studies in Indian population, it was found that world over it is 80% vis-a-vis 20% in our subset across all studies conducted here. So if it is 20% for oropharyngeal CAs, it is very unlikely to have buccal mucosa as a subset with 30%.
it's
It may be an
association.
association.
It's not,
Right. It
it's
may be an
association.
association. So what you need to know is what are the independent risk factors. So you said about tobacco, whether it is smoke, whether it is chewed form of tobacco. You said about areca nut. You also mentioned about tooth. So a sharp tooth or a chronic dental irritation per se is an independent factor. You need not be a habit consumer of alcohol or a tobacco chewer. A sharp tooth per se can cause such thing. Right. So can you enumerate any other independent factors, which means that no other factor, in absence of other factor, only the sore factor was the reason. Poor oral hygiene again is an association. It is not that I have poor oral hygiene, I don't brush my teeth, so I'll develop cancer. It's not like that. It's an association.
Do you know of any genetic factors?
Yes, ma'am. Fanconi's, ataxia, blooms, and leafrements. In all these, and recently added disc keratosis congenita can also cause, can also have. These are inherited cancer syndromes in which oral cancers can have.
Dr. Karthik, do you want to add anything or ask?
You mentioned in our history that patient had referred otalgia. So can you like enumerate the pathways through which the pain who is referred to the ear?
What he means is the
referred out as,
efferent and the efferent.
yes, efferent in for anterior tongue cancers is through lingual nerve, which supplies the anterior sensation for the anterior tooth of the tongue, and efferent will be auriculotemporal nerve, which supplies the anterior aspect of the pinna and external artery canal. So lesions which are involving anterior to third can refer the pain to the ear through this pathway.
Okay, so
Okay, and if the
which
lesion
means
is in the posterior third of the tongue,
Posterior tongue is supplied by glossopharyngeal as an efferent, and efferent will be tympanic plexus, which glossopharyngeal, which forms the tympanic plexus or the pedilia promontory. So it will be a deep-seated pain in those lesions through the same. And if a posterior, there is additional supply from the vagus, which also can refer through the Arnold's branch of the ear. It supplies the ear pinna.
it's not the pinna, it's the deep meatus. It's not the pinna.
Deep meatus, yes. Concha and the deep meatus.
okay,
Can I
so
ask
yes, sir, please continue.
Yeah, I just want to know that did you make any attempt to look for other primaries or dysplastic lesions in the oral cavity, or would you like to image the chest to see if the patient, I know he's not a smoker, but in what situations would you make an attempt to look for other primaries? Would you do it for a T1 or is it specific for advanced tongue cancers?
As a routine practice, we do Hopkins examination for search of an oral examination at the other sites initially, and followed by Hopkins examination to search for any other synchronous associated primary, second primaries.
Do you have any data to say what is the incidence of a second primary tumor in an oral carcinoma? Do you have any data? Or can you quote some papers on that?
Don't know, sir. Annual incidence will be 4 to 7% in head and neck, and the lifetime risk will be around 14% for second primaries. And oral cancers having higher chance of second primary in the oral cavity is that's the most common.
Yeah, so in your MRI, did you look for lymph nodes also? Because you only showed 3 cuts with just the primary.
Yes,
tumor.
sir. Yes, sir.
So
Yes, sir.
did you look for the lymph nodes also?
Yes, sir. It's
So
N0 status only for the
which scan sequence is best to see lymph nodes?
diffusion weighted imaging is better for
The problem with
lymph node
DWI is
imaging.
that you don't get that much anatomical correlation. It's just a value. You can't really make anatomical characteristics on DWI. So what specific sequence? So obviously you look at the contrast enhanced sequence, but is there any other role, any role of a T1 weighted sequence without contrast in any specific sequence?
Fat suppressed imaging of T1 weighted
Yeah,
can
so
give a
it's
good
a combination of things. It's obviously a combination of using
combination with
using contrast. But obviously, the point was made that you should know what you're reading in the individual sequences. What is the axial, what is the coronal, what the sagittal means. And never forget to look at the lymph nodes, obviously. Yeah.
How will you differentiate a reactive lymph node from a probable metastatic lymph node on the MR? T1 weighted with contrast. Hello, Dr. Teja?
Yes, ma'am. Yes, ma'am. Usually, on imaging, there is like they are round with short axis diameter more than 1 centimeter or in ratio with longest diameter, and there is loss of hilum with a central necrosis.
Fair enough. Okay.
If diffusion weight were added, it will be low ADC count, apparent diffusion coefficient. And if any extra capsular spread is there, there can be arbitration of the fat plane and capsular breach can be noted. Hello.
Yeah,
Okay,
go
Teja.
ahead.
So in this
We've
lesion,
done the imaging and you've enumerated the causes of malignancy, both the independent and the coexisting causes. Now, would you like to evaluate the patient with anything else, or would you like to go ahead and do the biopsy? And like the other moderators have told you that you can't
I
do
would
it.
like to do a metastatic workup, sir, along with the primary and neck evaluation. I would like to proceed with metastatic workup. Since it is a T1, T2 lesion, I would like to go ahead with the X-ray of the chest to detect for any metastasis. Although uncommon,
No, Dr. Teja, we first need to confirm that it's cancer.
Before biopsy, first I would like to go with biopsy to know with what lesion I am dealing with. So
okay, so what type of biopsy would you like to do in an ulcerative lesion?
it is better always to do incisional biopsy or punch biopsy can be attempted, but there should be inclusion of it should be including the most representative area along with the adjacent normal mucosa.
So what are the advantages of an incisional biopsy over a punch biopsy?
So in incisional biopsy, in punch biopsy there can be falsies by attempting a biopsy from the necrotic area. While in incisional biopsy, you can have an advantage by by having a small sliver of adjacent normal mucosa for which the pathologist is comfortable to compare with the tumor with the normal adjacent mucosa.
Oh, you need the adjacent normal mucosa, Dr. Teja?
Adjacent, at least adjacent sliver to compare with the tumor tissue.
Really? So have you ever attempted doing that? Adjacent normal tissue. What is the difference between most representative? Do you mean most representative includes adjacent sliver of normal tissue? Dr. Teja, I think you're putting yourself in a bit of a risk by saying that you include a sliver of normal. I would rest assured just say that it has to be the most representative site. Nobody really recommends a normal sliver of normal tissue.
Okay.
Does everybody agree?
Yes, madam. I do agree because the pathologist wants to assess the invasion of the basement membrane rather than the surrounding normal mucosa. So we need to take a deep incisional biopsy from the most representative area.
Okay, just going back a bit, Dr. Teja, you mentioned that your patient has reformed from his tobacco consumption habit. So if the patient has reformed since 5 months versus reformed since 5 years, does it make a difference to his risk of developing cancer attributable to that tobacco?
Definitely it reduces, ma'am, but it doesn't completely eliminate. Around
When does it eliminate? When does he become
it never eliminates.
equivalent to a never consumer, or it never? equivalent?
I forgot the paper to quote me. There is one paper.
There is. Please read up.
Yes, ma'am.
Otherwise, no patient would really agree to quit tobacco if you give him this reasoning that it'll never equate to a never consumer.
Yes.
It's actually quite similar to lung carcinoma and head and neck carcinoma. And actually, a lot of the data has been extrapolated from lung rather than pure head and neck. Actually, Harrison has a very good, I don't know if you read Harrison, the textbook, they have a very good chapter on chemo prevention where it actually lists out all these, they're quite old actually, but it's, I don't know if you read Harrison as a textbook. The chemo prevention chapter is very good. And the introduction, the first two chapters, what Mitali is asking exactly, all those points are given in those first two chapters of Harrison. If you read the lifetime risk, how many decades it takes, it doesn't matter how long they've smoked before. That doesn't quantify into how much they will regress when they stop. That isn't the equation here. The equation is the duration to which they have stopped and how much per decade the risk falls. That's how it's calculated. Every decade the risk falls to some percentage. So you have to go through that. Yeah. Please proceed. Sorry.
Okay, Teja, to
So-
continue, can you tell us about the AJCC 8th edition of staging of oral cavity cancers?
So, according to AACC 8th edition, T staging, TX is primary tumor can't be assessed. TIS is carcinoma in situ. T1 is tumor less than or equal to 2 centimeter and depth of invasion less than or equal to 5 mm or 0.5 centimeter. And T2 it is less than or equal to 2 centimeter tumor with depth of invasion more than 5 mm and less than or equal to 1 centimeter. And T3 it is tumor more than 4 centimeter or any tumor more than 1 centimeter depth of invasion. And T4 it is moderately advanced or locally advanced disease with invasion into additional structures like cortical bone, mandible or maxilla or the skin of the face. And T4B is very advanced disease, the tumor invading masseter space, pterygoid plates and skull base along with encasement of the with or without encasement of genital carotid artery. And it comes to the end stage, NX, yeah.
Sorry, please
Okay.
proceed. I'll
So-
ask you after that.
Yeah, so how do you define depth of invasion?
So depth of invasion is defined.
And how is it different from tumor thickness?
There are actually two techniques of how they measured that. So
Depth
you know
of-
the name of the techniques, how they measured tumor thickness and how they measured depth of invasion. There's actually named techniques.
horizontal line or horizontal line is drawn at the level of the basement membrane, and vertical plumb line is dropped to the maximum point of invasion. So you measure the depth of invasion by this. That means that for a ulcerative lesion, it is from the basement membrane level to the maximum point of invasion, and for a proliferative lesion, it is from the tumor surface to the maximum point of invasion. So it differs between ulcerative and proliferative lesions.
So where did they get the data to include the depth of invasion into the AJCC staging?
Ibrahimi et al. Is a paper.
So it was the ICOR collaborative. So if they ask you a question on how they came, you should know that they constructed models based on the other staging techniques that were available at that time, which also incorporated different cutoffs for depth of invasion, and the best fit model was what was selected. So you should know the ICOR paper quite well. In fact, the ICOR dataset has published several papers. All of the ICOR data papers are useful to read. because they have contributed to the AJCC staging now. Yeah.
Okay, so how would you treat this patient? Now you have found out it's a moderately differentiated squamous cell carcinoma and a T2N0. So how will you treat the patient?
So T2N0, N0 for moderate differentiated squamous cell carcinoma involving lateral part of the tongue. I like to offer this excision of the lateral border of the tongue with neck dissection 1 to 3 levels along with primary closure depending on the defect with adjuvant therapy based on the histopathological factors.
But I thought your data from Tata said that you shouldn't close it laterally. I thought you said that secondary intention healing was better in the tongue paper that you just published. Teja,
So
you're
Dr.
there?
Deepak is asking.
Primary closure I told, sir.
Yeah, but
Primary
then
closure.
I thought that you just published a paper saying that if you leave it to heal by second intention, it's better. I think it was Pratmesh sir's paper or something like that.
Mr. Paper, sir, he's doing, yes, sir. But
So that's what we've been saying for years, but no one believed us until you published it. So anyway,
Rightly
so
so.
what are the other types of excision that you can offer this patient? You said you do a wide local excision with 1 centimeter or centimeter and a half margins, whatever. Is there any other way of surgically approaching this patient? Is there any other type of excision that you know?
parallel approach, so this is the lesion
No,
is
I'm asking you the
locally
extent of resection. I'm not asking you the approach. I'm asking you the extent of resection.
into say classification of the resections of a tongue. So
No,
answer and at all.
I'm asking you, do you know that there are people who have done compartment excisions for T2 to T4
Yes, sir.
regions? I'm not talking about T1. I'm talking about T2 to T4. Calabresi's data from Italy, and they have points percentage improvement. So what is
Yes,
this
sir.
compartment excision? Let's say this patient is asking you, I don't know what the difference between a wide local and a compartment excision. So what is the basis of a compartment excision?
So compartmental excision is defined as again uh, wide excision of the primary along with all the ways of loco-regional spread. For example, we coined it in 3 terms: sir, glandular, periglandular, and perineural, along with the neurovascular bundle and a myloid sling. For example, sublingual and submandibular glands along with the lymph nodes and myloid along the myloid muscle and lymphatic chain along the floor of mouth. So this constitutes the compartmental dissection. So this is attempted for tumors which are spreading through along floor of mouth and the midline raphe into the sublingual space specifically. They have attempted
You haven't
this.
defined the. You said the medial extent is the midline raphe, inferior extent is level 1B. Posteriorly to what muscle will you cut? The compartment constitutes of what will the posterior extent in the posterior extent? I think it includes the styloglossal muscle at the posterior end. So it's a median raphe, styloglossal at the end, myloid in the inferior, and inferomedial is the sublingual, like you said, the things. So what was their logic of doing it? Why is it such a big thing in Europe and not here? Why do you think
There is a
what is the
term
logic
called
behind it?
tumor nodal tract, sir. So entire tongue cancers have propensity to spread along this tract. So excision of the tumor along with this nodal tract has given loco-regional control.
Why is this local regional control better there and not here? I mean, it is at par. So what is the physiological basis of doing this compartmental resection? Dr. Teja, are you there?
Yes, sir. Yes.
So
I
what
don't
is
know.
the physiological basis, as
Is there an
Deepak said?
embryological reason? Is there an embryological reason for this? So I think Calabrese has two papers. One is the results paper, one is the principles paper.
Is
And we've just for you to know, we've just finished comparing our data with Italy in a propensity matched paper, and we found that the control rates are actually equal. Their paper said 16% something better local control, 23 or 24% better overall survival for T2 to T4 tumors, which didn't really pan out. And how can you do a compartment for a T4 lesion? It makes no sense.
only.
Yeah, unless it's involving the bone or something, it makes no sense. So, but it's a fun question everybody asks in the exam because, you just compare two different types of resection. So I hope you get to read those two papers sometime. Yeah, good.
Dr. Teja, do read those papers, because eventually the Italian way, you end up resecting more and achieving the same.
And you're creating a fistula also.
Absolutely.
You're creating a huge oro cervical fistula or something.
Cervical
Because, and then you have to reconstruct, you are forced to reconstruct also
Post to
for
reconstruct.
marginal benefits. But their benefits were very high. I don't believe that data even today, but what we found was that when we compared our data with theirs, it was similar. So it makes
But
no difference.
they describe intrinsic metastasis along these tracts, so that's the major reason
Yes.
concern.
There's a picture of that in their paper also. They split open
Yes,
one
sir.
tongue. It shows some nodules going towards inferiorly. Yeah, it's there. Okay,
So,
I want to ask you a very important
okay, sorry.
question. Sorry, Mitali, you please go ahead.
So,
I'll ask
Dr.
you.
Teja, give me the indication of doing of requirement of doing a pull-through technique or a technique by which you'll have to create a communication with the neck in if even in a wide local excision. I mean, which areas of involvement mandate the need for a pull-through?
So ideally, pull through is attempted whenever the lesion extends posteriorly, or
Why do you
when
need to do a pull-through?
parallel excision with the posterior with the lesion is extending posteriorly, parallel excision becomes difficult for the posterior margin or the posterior boundary, and
Is it a
particularly in
posterior or
patients having
inferior extent? If you have a posterior third tongue tumor, you can do a mandibulotomy and excise the tumor.
Mandibulotomy. Absolutely.
mandibulotomy.
Yeah, but if you see, the whole problem with the pull through is that you devitalize the entire floor of the mouth. In a mandibulotomy, you only resect or you only incise one specific sulcus to reach the tumor. So if you have a tumor that is involving the mylohyoid and submandibular gland in continuity, I think a pull through is better there because you will get one block of tissue out. But yeah, I would agree. Posterior third tongue extension is one of the indications for pull through. But the whole problem with pull through is you have to suture the whole floor of mouth back again. But there is a meta-analysis which says that pull through is better than mandibulotomy in terms
That
of
is
leaks.
a contentious issue. There are a lot of naysayers of mandibulotomy vis-a-vis a pull-through.
Yeah,
But
I mean, mandibulotomy is not, I wouldn't do a mandibulotomy first because the hardware is just a problem. Putting
that's
those
correct.
plates and screws is a problem.
So let's stick to concept this. Which all areas are difficult to resect per orally is my question. Dr. Teja,
Mm,
you said posterior extent. I think unanimously we agree. Anything else?
Yes.
posterior and posterior lateral, like extending onto the tonsil and TLS is one, and
That's holding the ear with the hand
inferior
on the
floor of
opposite
mouth
side.
as yes, inferior along the floor of mouth extend.
Yes. So if the disease is on the ventral surface, yes. What else?
Third, particularly.
Okay, fair enough.
Would everyone agree with him saying 1 to 3 neck dissection, or is that fight still going to be there for 1 to 4 neck dissection? What is the what is the final statement now? In the exam,
Probably
I'm
every
asking.
second,
I'm not asking
probably every
from a
second or
practical
third
point.
year, a resident from one of the institutes is publishing 1 to 3, 1 to 4, 1 to 3, 1 to 4. All the meta-analysis around the globe is still struggling to find out what is 1 to 3 and what is
Yeah.
1 to 4.
Correct.
So there is nothing which is evident as to 1 to 3 vis-a-vis 1 to 4. But yes, there was a meta-analysis which was done. But in an N0 neck, I think it is still, I should say, okay to do a 1 to 3. But fingers crossed, I mean, nobody will be wrong if he says 1 to 4.
So, for the purists, what was Byers' data and what was the follow-up data to Byers? Do you know, have you read Byers' paper? Very old head neck paper, very, very old. And then there was a follow-up data to the same paper, which, Teja, do you know that? Then we had
Bias
something from,
for the skip matrix, Diaz
sorry?
data and bias data. Diaz data and bias data.
Yeah, Byers was first
And
and then
Bias.
Byers later, yeah.
And yes,
Or would you know what was the publication from Jatin Shaw when he looked at patterns of lymph node metastasis in upper aerodigestive tract tumors? What was the site which was specific? See, he had done R&D for all the patients, okay? So it was a very aggressive surgery what they had done. But you know what are the common sites in a tongue? Is it common to have level 4 metastasis? And if there is level 4, what would be the pre sort of things for that metastasis?
N0 neck, ideally in the present scenario with available data, the skip metastasis is around less than 5%, sir, the available. And recently Anton Warnowski has published a meta-analysis, and in that also if we take bias data, which is approximately of 15.6% of the skip metastasis, ideally the true metastasis in the bias data is also around 5%,
Only
true
that
skip
much. Right.
metastasis.
Good, man.
And in the DIAS data, it is around 2.2. And in the same paper, Balasubramanian sir, there is one more, that's 1.34%.
What is
Yeah.
the findings of the data that came out from TMH, the largest prospective study?
So
looking at-
583 neck dissection, the
So what did that
prospective
show?
study. So in N0 neck level 1 to 3, if we address, you're going to clear 91% of the involved lymph nodes, and if you add level 4 to that, it amounts to 96%. So this is the one study which tells that addition of level 4 to the already existing level 1 to 3 can clear almost 96%. But otherwise, if you see the skip metastasis in this study, uh, it is approximately 17.5% to the level 3. Level 3 skip metastasis 17.5%. So inclusion of next level of lymph node, that level 4 is gives a better curative treatment than not including. This is what concluded by this 583 neck dissection study.
Good, man.
Based
Now
on this, it is level 1 to 4.
the questions always will be level 4 and level 2B. So now what is for level 2B?
So, and in the same paper, it was quoted in tongue cancer specifically, for which echelon is 2, level 2. So, level 2A is independent determinant of whether to proceed with level 2B or not. And it's the same with level 5.
So in this whole, sorry, go ahead.
No, please go ahead.
So in this whole scenario, Teja, would you, in your surgical management, would you factor frozen section in a patient of T2N0 for either the primary or the nodes, or it's not required?
Yes, ma'am, frozen section. helps us
Specifically,
and
what will you send for frozen section?
I'll send primary, and along with that I'll send level 2A.
Now, would you send patient side frozens or specimen side frozens?
Specimen driven approach is better than patient. There's a paper from the TMS, sir. So specimen driven approach is always better than patient driven approach. And moreover, if you ask for the primary, the frozen doesn't add anything. And there's one more paper comparing frozen section with the gross clinical examination or palpation. So by Pankaj sir, so it told like palpation for the three-dimensional margins gives a better it's a better technique, and frozen is an alternative for that. And similar paper, but again next paper by Saurav et al. And frozen doesn't have a cost benefit advantage for the treatment based on this.
So in other words, frozen doesn't add any value when you are resecting the primary. What
For
about
the primary, for the primary.
What about the
And
neck?
for the doesn't add advantage, but we have routine practice. Whatever we do is on frozen, if you have a margin.
No, that's because the facility is available. You see it in the holistic view. Yes, you have a couple of papers which suggest that the frozen section vis-a-vis clinical palpation and resection margins don't match up to the cost benefit analysis. And I think we should agree to that. The second part of the question was, what about the neck? We discussed it vis-a-vis 3 to 4 dissection. You said about scape metastasis. What about the neck?
The role of frozen in the neck, sir?
Yes.
Our practice is to first to send level 1A, sir, for frozen. So if it is positive, they have quite a few papers that if the lesion is coming onto the midline or just reaching to the midline, we need to address a contralateral neck. And if level 1A is positive, it is like
undoubtedly for last decade and a half, undoubtedly. What about beyond? We had a discussion about 2A, 2B, 3 and 4.
yes, since the first ocular node is 2A, so I like to send it for frozen. If it is positive, I like to proceed with level 5 and 2B dissection with that, based on this paper by 583 neck dissection paper, prospective study.
In that 583, it was 2.83 or 2.78%, right?
Sir?
It was 2.83 with a 2A positive at level 5.
Yes, sir. Yes, sir. It's only
right?
less than 3%. And 2B is around 2 points. Yes, sir.
Correct. So would you still like to address 5?
If
and not do a comprehensive
is positive, it's
to 4?
Independent determinate, so we'll go with and we proceed in Tata. Ideally, we proceed with any low-lying lymph nodes which are positive, like level 3 and 4. In that case, we definitely
Yes,
address
then it is
level
comprehensive.
5. Yes. And second thing, there's one more paper by Paleri et al., which also describes about level 2B, which is around 2.3% in oral cancers. So there can be always level 2B sparing based on level 2A status.
So if meticulous dissection is done, why can't level 2 be taken as part of routine 1 to 3/1 to 4?
And yes, sir, that can be done. There is another school of thought that level 2 and 2A and 2B are just separated by arbitrary spinal axis. There is no clear boundary for that separation. So there can be every chance that you can leave a lymph node thinking that it will be level 2B and can be a part of level 2. So yes, there is another school of thought for that.
Any difference in survival?
I don't think so. I don't know. We ideally address level 2 as a single chain with preserving spinal axis no function and integrity.
So let me put it this way: in in your opinion, in your wisdom, when should you address level 5?
Multiple levels of lymph node involvement, low-lying level lymph node involvement is a frank indication for doing level 5, sir. And if it is not done, so this is once multiple level lymph nodes and low-lying lymph nodes with high nodal burden at the low-lying lymph nodes.
Would this patient be a candidate for a sentinel node biopsy, Dr. Teja?
Yes, ma'am, definitely T1, T2 based on the available data by Garrel equivalent study and the Japanese JCO publication describing that sentinel lymph node is a non-inferior to the elective neck dissection technique, and sentinel lymph node based neck dissection is not inferior to the elective neck dissection.
So more than T1, T2, it is N0.
N0, yes, sir. T1, T2, N0.
But there were some pitfalls in the SEN trial. No, there were some problems with regards to false negatives and things like that. So
Even there were some pitfalls in the Japanese. You
Japanese.
quoted
Correct.
the Japanese study Hasegawa. Could you,
Yes.
if you, I mean, you seem to be very well read, I must say. Then tell us the pitfalls of this study, and if you could tell us that, then
Hello.
enough.
So there is in Japanese trial, the occult lymph node detectivity of the central lymph node is around 26%, and they have tried to see whether there is any survival benefit of doing SLNV based neck dissection.
What was the primary
during
endpoint in Hasegawa in the Japanese
Wait.
study?
that is very important, actually.
No, they looked at overall survival, so it was a fairly well done study.
Survival and functional.
Yeah, but they looked at overall survival as a primary endpoint, so it was a fairly well conducted study. But the you may not call it a pitfall, but one of the concerns, not concerns, but one of the this was problems was the performance of the frozen section. The sensitivity was not more than 68% in spite of doing 2 mm cuts. So that is something which really needs to be looked at, even in a trial setting. The performance of frozen section or the intraoperative detection of metastasis per se was not upwards of even 70%. So yes, it is not something that will be very widely recommended even now. It has to be done with a lot of caution. Dr. Teja?
Dr. Teja, is it the network problem, or we all are getting you too foxed? All right. Now, could you summarize? Could you summarize as to how we deal with the T2N0 tongue in our Indian setting?
I think Dr. Teja is gone.
Jogging?
I think he's logged out.
All right.
Oh.
Maybe poor connection. Granted to the youngster.
Yes, I'm
He's
back.
back. He's back.
I think this is the-
Oh, wonderful.
He's showing over there. Yeah.
So, Dr. Teja, let's conclude the evening meeting. So you have a T2N0 young gentleman with the tongue cancer. So eventually, can you summarize the entire discussion as to what you will offer this patient, how you will counsel this patient, and what is the endpoint?
How will you prognosticate this patient also? How will you counsel him with respect to prognostication?
I would like to counsel this patient for surgical as a treatment option. And I would like to tell him that I will address primary along with the neck, and depending on the resection, we are going to plan for reconstruction. And most probably it entails primary closure in this case based on the available clinical radiological picture. And after that, I would counsel that based on the histopathological report, we put the parameters and other parameters, you need to may or may not need to undergo adjuvant chemo radiation or radiation depending on the parameters. And at the end, I would like also to explain that is rise to dependent. He will be rise to dependent for around a week,
Very good.
and in this patient, most probably the speech will be returning to normal in around almost around 2 to 3 months. If it is anterior, there can be speech defect with that, speech deficit with that, and I would always encourage in the post-op to swallow saliva for the early retinal swallowing function. And I will definitely address the patient to consult a speech fellow therapist in the post-op for the
How will you
rehabilitation.
prognosticate it? If he
with,
asks you what is the
along,
prognosis of my tumor?
so it's a T1, T2, and around 85% oral survival is expected with that in the early cancers. And but
No,
if
you
the
talk about tongue. No other subsites. Talk about tongue. Prognosticate the tongue for a T1, T2, T2 lesion.
I'm not sure of percentage, but
No, fair enough. Go ahead.
Go ahead. Let me assure you, I'm
and I
not
would
coming as
also
your examiner.
ask the sir?
Go ahead.
And I would also ask the patient to consult physiotherapist in the post-op, so to avoid any surgical related fibrosis, or along with that, neck exercises can be advocated to the patient completely. And I will tell also the patient that he needs to follow up regularly in the after post-op completion of the treatment.
What will
Completion
be
of the
your
adjuvant
follow-up
also.
regime like?
So 3 monthly follow-up for initial 2 years based on clinical examination, and 6 monthly follow-up for next 3 years, and yearly follow-up after 5 years. So if any suspicious lesion or any other patient is complaining of any pain which is unbearable, so I would like to investigate with radiological investigation to see for any recurrence.
So in prognostication,
Otherwise, clinical examination is sufficient.
fair enough.
So,
You need to think in two ways. If after the primary resection, no adjuvant was required, then the follow-up regime will be slightly different. And if adjuvant is required, then the follow-up regime will be different because he'll be then visiting multiple subspecialties of oncology. So if it is a primary closure, no adjuvant required, then you would like to see him a little more frequently for the first couple of months. And thereafter, as you said, 3 monthly, and then 6 monthly, and then annually. But if there an adjuvant is required, then he goes to a couple of other specialists also. And accordingly, you taper off 6 weeks post-RT and all those things. But what is important is what you rightly mentioned, that rehabilitation pre-surgery and post-surgery is very important. The eventual outcome and the outcome, whether it is in terms of local survival, whether it is in terms of overall survival, is something which is very limited in your hands, besides a good margin, good clearance of the neck. But quality of life is all rehabilitation. So you need to emphasize on that. Your team needs to emphasize on that, and pay attention to that. Right?
yes, sir.
I would request all the panelists with a final thought, please.
Yeah, just one last thing. If the patient has spinal accessory nerve dysfunction post-op, how would you rehabilitate that patient? Can you tell me what are the passive exercises that you would advise the patient? Can you tell me whether the patient needs an ENG, EMG? How would you manage a patient who comes and tells you that he is having problems lifting his shoulder, abducting his shoulder post-op? And even if you do a nerve sparing 2 to 4 neck dissection or 1 to 4 neck dissection, still a large percentage of patients can have transient spinal accessory nerve syndrome. Up to 10% of patients can have permanent spinal accessory nerve syndrome. So how would you like to advise this patient or rehabilitate this patient?
Not sure of the exercises, sir, but
There's a 2002 paper by Salerno, which was published in Laryngoscope, that has detailed all the exercises that you teach the patient, including passive elevation of the shoulder, how to internally rotate the shoulder, all those things. And I think that every patient should be evaluated for spinal accessory nerve dysfunction post, because there are two things. It does not mean that you damage the spinal accessory nerve alone. It can be neuropraxia, can be stretching, whatever. But if you do a level 5 neck dissection and damage the supraclavicular nerves, they will still cause pain in hand movement, in shoulder movement. And then the patient will have develop adhesive capsulitis and will live forever like that. So please read about spinal accessory nerve rehabilitation. Actually, e-medicine has a very good article on that. It's free article for you to read. E-medicine has a very good article on spinal accessory nerve rehabilitation.
yes.
Yeah, that's what I wanted to say. Thank you.
Very pertinent point, because if he's a right
Sir,
Yes, I was logged off actually, but I just came back in. Sorry.
so you told in the last class you'll be telling about SFT and SPT.
Yeah,
If
yeah. So basically, it depends upon the origin of the cells that we are talking about. If you look at the classical Warren Gates definition of second primary tumor, they didn't take into account whether the origin of the second primary tumor is from the same index clonal malignant tissue or whether it was from an independent clone of malignant tissue. So basically, when this paper that was published by Brackwis is very old, it's 2000 something, I think 2001 or 2002, it's very old. But the concepts that they had explored was that if the patient develops a tumor that is clonally related to the primary tumor, it can be metastasis or it can be another primary, then you call them second field tumors because they're from the same clonal origin and they're not true second primary tumors. But if you have an independent clone developing somewhere else and that forms a malignant tumor tissue, that is a true SPT, a true second primary tumor. But then there has been no follow up on that. They have advised us to do molecular testing, genetic abnormalities, gene additions and deletions to see if the two tumors were related, but nothing has been published beyond that. So in a sense, it depends upon the origin of the second tumor. If it's clonally related, it's a second field tumor or metastasis. If it is clonally independent, it's a true second primary tumor. So that's what the Brackwis paper was about.
okay. And sir, one more thing, I just want to ask this. So in recent ages, you see, they have removed the term called greatest dimension of the tumor.
Yes.
So why is it removed? If it is removed, so then they have concentrated since on depth of invasion. So they have removed that, or any other reason for removing that word of greatest dimension?
The problem with the AJCC manuals is they don't give any specific explanations. They give references, but even the new staging manual doesn't have any new references from what they had published almost 3-4 years ago. So I think it's more emphasis on depth of invasion rather than the transfer spread. The depth spread is what is more relevant, I think. If you look at the tumors that have been upstaged based on maximum dimension versus tumors that have been upstaged based on more depth of invasion. Depth of invasion has been found to be more prognostic than the superficial transfers, the anteroposterior diameter. So I guess maybe that's the reason. I'm just speculating. I really don't know.
No, that's what probably the reason behind removing the greatest dimension is because the depth of invasion also can be greater than the length and the breadth. But that doesn't mean so if it's a 1 centimeter depth of invasion and a 0.5 centimeters antero-posterior, but still the depth of invasion remains the depth of invasion. It
Correct,
cannot
correct,
be the
correct.
other way around. I mean,
Correct.
So you
So I
mean to
guess-
say
So
only
that is
length
why-
and the
length, breadth, and depth are all three of them are equally important. I mean,
in the tumor stage. So we are keeping the depth as a side along with that.
exactly.
And why they have retained it for nodal, sir? If there is any reason for the nodal status, they have retained it.
Yeah, obviously,
Um,
because it doesn't matter, no? The greatest dimension of the node is what is important, and ENE is an additional main, independent of the dimension.
See,
So,
when they
and
published this nodal staging, AGCC, they didn't have any level 1 evidence to change it this time. It was just collaborative from MSKCC and Toronto. They just published the data set. But I agree, the length, the size of the node is important, ENE is important, and the laterality of the node is obviously important. So these three things you have to look at node staging. But I agree with what Mitali said, that the depth in so many instances is much more than the length of the tumor. If you look at the final histopathology report, it is more than a centimeter, whereas the superficial extent of the tumor is like, it doesn't make any sense. It's 2 centimeters, so it's if you stage it by greatest dimension, it's understaged. So there are a lot of instances, especially in tongue like this. So I guess that was the reason. Probably it's more important that the greatest dimension can be the depth also.
but for sarcomas, they have retained it, sir. For example, oral sarcoma is there for the maxilla or the mandible. They have retained that statement of greatest dimension. Then
I
and
don't know.
my one
Probably
more
they
thing,
have some. I don't know. Maybe they have some
and one more
related
doubt
long bone
I
sarcoma.
have is if you think in the tumor growth or dimension, then they have to retain it for sarcomatoid carcinoma also, which is the other variant of squamous cell.
So, may I interject? Actually, for sarcomas or sarcomatoid variant, actually the data is not readily available. So initially, what we were following for sarcoma for head and neck was the staging system which was being used for long bones and the extremities. But later on, they changed the criteria in the recent AGCC staging. They have changed the size to 2 to 4 centimeters instead of 5 centimeters in order to generate or gather more data and see how the outcome comes out eventually when we retrospectively analyze our data in the future.
I think they've done the same for non-melanotic skin cancers also.
They have mentioned this in AGCC, their edition as well, that why they have changed this and this 2 to 4 centimeter from 5 centimeter.
So, for example, for oral sarcomas, you stage it as sarcoma or you stage it as a oral cancer. The same with mine, salivary gland tumors. Then, for example, some salivary gland tumor in the oral cavity.
Teja, you tell us, please.
I don't know.
So for sarcomas, you have to, as per the recent guidelines, the sarcomas are staged, oral sarcomas are staged as the limb sarcomas together. So less than 8 centimeter, more than 8 centimeters, they are staged that way and not as per the subsite now. So this is a recent update that we have.
Thank you, sir. Okay. Sir, one more question last. Involvement of the neurovascular bundle is not included in the staging. Earlier, there was like hypoglossal nerve and deviation of the tongue, and specifically in tongue cancers. Hypoglossal nerve involvement is thought to be as a cause.
Even extrinsic muscle involvement is no longer included in the
No
staging.
longer, but
So even if the patient comes with ankyloglossia, would you call it as a CT4?
no, not at present. No.
Yeah.
On the topic of perineural, you have to go through, there's been a lot of data on whether just calling it I know Deepa had published just perineural versus no perineural, but then the subcategorization of perineural also is important. If you read the paper from Sydney, which was published in Journal of Surgical Oncology, they looked at name nerves, no, not name nerves, they looked at
Name.
large nerves, small nerves, single nerve, multiple nerves, whether the nerve was involved within such a distance from the neurovascular bundle or whether it was out of field involvement of the nerve. So I guess subcategorizing PNI also is important. And there's so much data now asking for PNI to be included in the next AJCC. So most likely, we did a collaborative paper with Ziv Gill in Israel, and we found that it upstages the tumor by 1 T stage. If the pathological report comes as PNI positive, irrespective of subcategorization. And then, now the T2 PNI trial is going on. So I guess
Yeah.
PNI will become more important in the next AJCC. I'm very sure they're going to include something about PNI, pathological PNI in the next AJCC. We didn't discuss that today, but it's just a topic that you should remember. Karina is the name from Sydney. That is the data that they had published with their data set. So just go through the PNI stuff also.
Yes.
Good evening, everyone. I think we'll stop the discussion here. I have an announcement to make. So from next session, the next discussion that we are going to have, so we will have a 15-minute seminar come a journal presentation. Each presentation will be followed by the case discussion. So that will be upgrading your further knowledge on the newer advances. And for today's, it was a wonderful discussion. So everybody chipped in. So there was a constant discussion and inputs from everybody. And I like the way that Teja himself got some confusions because he has been reading afresh and he has got with fresh questions whether how you are going to stage the sarcoma. This is a very important question. And we always tend to forget because of the CAP protocols that we follow for the pathological staging. And that's a very good thing that we have started. That's a very good discussion. And I would say it over to Dr. Ravi Shankar.
Hi, thank you, Dr. Asim.
For the thank you note.
Thank you. First of all, I would like to congratulate Teja for such a fantabulous and wonderful presentation. It is definitely not easy to come on this platform and present in front of so many people, but yet this has got its own advantages. Presenting in presence of so many eminent faculties is a rare opportunity. And we should all learn from Teja and for grabbing on this opportunity. I would also like to thank all the dignitaries and all the eminent faculties who have come today, especially Dr. Deepak Balasubramaniam sir, Mitali ma'am, Raina sir, and Dr. Karthik. And our next class would be on 27th of January. I would be circulating the flyers very soon. I would again like to thank you all for your time. Thank you so much. I think we can end the session and log off now. Thank you, sir. Thank you, ma'am. Thank you, Rana, sir.
Okay, thank you, Ravi.
Thank you,
Very
everyone.
nice initiative this is for all the residents. Thank you.
It is good for all of us, actually. Learning is an ongoing process and we all learn from this kind of initiative. Thank you, everybody.
Thank you, everyone.